Welcome to Sports Doc Talk. I'm Will Sanchez. You know who I am. This is Dr. Grant Garcia, our orthopedic surgeon and sports medicine specialist. Dr. Garcia, how are you? Let's just start off. We're really excited about our guest, but I always want to say how you're doing, what's going on, and our Giants once again are. We won't talk about the Giants. We'll just move on. How are you? Let's talk about that.
I was hoping you weren't going to say anything. It's always one of us that brings it up. But you know what? I'm good outside of that. Life's good. We got some great guests coming on. Super excited about this. So this will be really good.
Yeah, we had two incredible guests, but as we always do, we want to make sure that we take care of the folks that take care of us, that take care of our patients, or more importantly, your patient. The Recovery Shop, and let's talk about Mike B at the Recovery Shop and how good they are.
I think that's our new slogan: takes care of us, that takes care of them, that takes care of the patients. I like that. I'm going to tell those guys. So big shout out to them, Mike B, for sponsoring us. They're great. It's really nice for the surgeons to have these sort of aftermarket options for patients. It's literally today I had probably 5 people ask about it. So it's really nice and concise. The patients really like it. We love the nice machine. We're really loving some of the other products. This nutrition is huge. We're going to talk about some other things today that are really important for the post-operative and preoperative portion of surgery. So they do a good job. But without further delay, we want to announce our really nice, great guests.
Yeah, today we're talking about something that, every parent, coach, athlete thinks about. What are we doing? What's right for our kids? Also, how can we keep playing as we get older without breaking down? We've had this discussion many a times because I am an older weekend warrior that have broken down, and we're always trying to make sure that we could get things legit. But let's bring on some folks that know what they're talking about and can help us in these areas. Like to welcome Dr. Starman and Dr. Winter. Thank you so much for being here. I'm very excited that we have 4 people. We have this Hollywood Squares thing kind of going on. If we had a center square, would be good to go. But welcome to the show. Thank you for being here.
Great to be with you guys tonight.
Yeah, thanks for having me.
Yeah, so you guys both come from OrthoCarolinas, and for the listeners, it's a really, really prominent orthopedic institute, orthopedic, conglomerate down over there in Carolina. And so it's really great to have you guys on. And I know you guys have a strong emphasis on a bunch of different things, but I think kind of to start, and we're going to jump around just to make sure that everybody gets to chat. But Jim, why don't you tell us a little bit about, I know you said you emphasize in a bunch of different things, right? The shoulder, knee, and some cartilage. But kind of talk about your background and what brought you over to OrthoCarolinas. I know you trained with Freddie Fu, rest in peace, but very prominent orthopedic surgeon. Maybe talk about how that influenced you and et cetera.
Sure. Yeah. So I'm originally from Pittsburgh, which, as fate would have it, led me to Dr. Fu. And so he was a big influence in my early career and honestly in my choice to pursue sports medicine. So I had a chance as a medical student at the University of Pittsburgh to work with him, take actually a whole year off of my medical training to work with him. So I got a chance to sort of see how he treats athletes from all over the world, which really influenced me significantly in choosing orthopedics and choosing sports medicine specifically. So feel really blessed to have known him. And obviously, it's a great loss that he's no longer with us, but his legacy certainly has lived on in a lot of other people. So we're really fortunate for that.
Awesome. And what do you do currently? Will you talk a little bit more about your practice at OrthoCarolinas for the listeners, especially some of the focuses?
Sure. So I focus on a lot of sports injuries, of course, and also the weekend warrior population makes up a big part of the people I take care of. So it's really kind of cradle to grave as far as the knee is concerned. So I do anything from cartilage restoration, microfracture, Oates procedures, all the way up through knee replacement, and similar kind of profile for the shoulders, from cradle to grave for the shoulders.
Awesome. And Dr. Winter, can you give us kind of your background too? I know you're kind of your same. Are you guys in the same? I know that OrthoCarolinas is actually quite large. Are you guys in the same sort of subgroup, or you guys work on different areas, different offices? And then we'll give us sort of your background too. I know you did a little more of a shoulder focus.
Yeah, Dr. Starman and I both work in the Winston-Salem office, or in like the Triad area, which is Winston-Salem, Greensboro, Kernersville. So we work together fairly regularly. And my journey to sports medicine came from playing soccer. I grew up playing competitive soccer and then played in college at Vanderbilt. You got a chance to hang out with the sports medicine guys there at Vanderbilt during my time. Just really enjoyed the time learning from them and getting to see what taking care of athletes looks like. Not only from folks they took care of local high schools around Nashville, but taking care of us as athletes at Vanderbilt, and just kind of spurred my interest to keep pursuing that and moving on to med school, and then fortunately had the opportunity to train at Stedman Hawkins with Dr. Hawkins, and really learned a lot about the shoulder from him, and really spurred my interest in shoulder surgery, and move forward to where we are today.
And for shoulder, do you have a specific thing you like to focus on, or you do more arthroscopy, combination of that, replacements, or kind of are you more sports shoulder focused? How does it work for you?
A little of both. I do some traditional sports medicine, knee and shoulder arthroscopy, and then open shoulder as well with shoulder arthroplasty and fractures.
And I think you guys probably can each answer this separately, but kind of what drew you to OrthoCarolina's? Obviously, big name. I looked at that for a number of different things, from fellowship to residency, et cetera. What drew you guys? We could start off, from right to left, but what drew you guys to OrthoCarolina's?
So from my perspective, I actually did my residency in Charlotte, North Carolina, and Atrium Health, his partnership with them. So I actually got to know a lot of the partners in this group as a resident, and they kind of brought me along and helped train me. And I did my fellowship at University of Virginia, and then I went into private practice initially in Florida. But after a few years, we decided that we wanted to come back to the Carolinas. And so thankfully I had some contacts up here and was able to, come at the time when there was an opening in the Winston-Salem market. So that's where we ended up. But we've been real fortunate to come back.
Awesome.
Yeah, Dr. Winter, what kind of drew you to the specialization? You mentioned that you had a soccer background, but for you to focus on shoulder and elbow, what drew you in that field? Because I don't equate soccer with the shoulder and the upper body with the arms. So what was the correlation there?
I really didn't grow out of my interest in soccer. Soccer kind of pushed me into sports medicine in general, and then the exposure to it during training, just the variety of things that you see in the shoulder, the complexity of it, and some of the challenge that I just found very interesting as it relates to taking care of even young kids with throwing injuries to older folks with rotator cuff injuries to shoulder replacements. Just really get to see the gamut of population, and I just found it very interesting and fascinating that the different types of surgeries and rehab that you could to do within the shoulder.
Go ahead, Dr. No, what I was going to say was, did you have an experience, with seeing the shoulder injuries? When I think about sports injuries, especially for youth, it's either football or baseball when it comes to shoulder injuries. So there was an uptick, or there's something there that kind of drew you, where you wanted to help? Because I know Carolina has an emphasis on serving the community and being a part of it. How does that all kind of intertwine with what you do with youth sports and Carolina committed to youth sports?
I think probably the biggest thing we see for youth sports with throwers is throwing shoulder and throwing elbow pain. There's a huge number of kids who are playing baseball and throwing on a regular basis, that especially during the middle school years, when you start to play middle school ball and travel ball and little league, and a lot of those overlap, you end up throwing a lot of pitches or throwing a lot of bullpens and warm up and cool down, and your pitch counts start to rise. And so you see a big uptick in kids that have either throwing shoulder pain or throwing elbow pain. Just being able to kind of walk those families through the process of this. Yeah, this isn't the end of your career. This isn't something you need to retire from baseball at 13 or 14. Now we can get you through this. We can rehab you, and we can get you back throwing again safely and effectively, without really being high risk for long-term injuries.
I think I want to follow up on that. I like this. This is good. So this is not always going the right direction, the directions we're thinking, which is good. So can you fill in the listeners? This is a big thing. We have a lot of people actually listen to podcasts and their families that come in, not just in salary, but they'll come in maybe your office and they'll have heard this, but they're really concerned about their kids' throwing ability. It's less football, much more baseball. I'm assuming that's the same way in your situation where you've got like two parents, a coach and a trainer, and they're all in the same room when you come in to talk to the player, right? And they've got a high interest in this. Like, how does that conversation start with you, right? Maybe you're lucky and you've had the MRI, it's something that they need surgery, or maybe they don't have anything, or maybe you have information, it's not that bad. Like, how do you kind of start that conversation with the players? And I will say mostly baseball, right? The parents think they're pro, they're probably not pro, but you got to figure out a way to navigate that. How do you deal with that situation? It's just probably interesting for the parents to hear this as well.
I like to just hear where they're at right now. I like to hear what they've been doing, where they're playing, what teams they're playing on, what coaches they're working with, and just try and get a sense of the overall amount of work that they're doing, the amount of throwing they're doing, and try and weave into that who's really keeping track of the pitch counts. Because oftentimes you can see that nobody's really taking care of the pitch counts. Coaches may be watching them for their particular game with the travel team, and then high school or middle school may be watching that team, but nobody's really counting up all of the pitch counts. So trying to assimilate that and get them to see what we're seeing, which is that this tends to be overuse and not a specific event that their thrower had, and kind of walking them through seeing how much they're throwing and how much they're working outside of practices and how much they're not really keeping track of their pitch counts tends to lead to these overuse types of injuries. And then let them kind of sort through how do we move forward from that without overwhelming the risk of, everybody wants to get to Tommy John immediately, right? That's not overwhelming that discussion and just, trying to walk them through that. If we're not convinced that there's something bigger, obviously if there's something bigger, then we go to imaging and have those discussions.
Awesome.
I think that's a great point that Brad makes. And I would add to that as well, that I think it's really important that you understand kind of the goals of the athlete and not necessarily just the goals of the parents or the coaches for that athlete, because that can also inform a lot of kind of how we counsel these types of conversations and trying to allow them to continue to enjoy the sport that they're participating in and not just doing it for the wrong reasons or with this pursuit of perfection that they may never achieve, and just trying to help guide those conversations and maintain the focus on letting these athletes enjoy their sport and enjoy their participation.
I think that's a really good point. Will, we've talked about this. The focus is on player first, then everything else around them, right? And what do they think? And sometimes, like we were making the kind of, I don't want to say a joke, but when they come in and they, one person thinks they're pro and the other one's just like, I like playing baseball because it's fun. I play with my friends. The conversation changes a little bit different. And also what their caliber is, right? I mean, you have to kind of modify your conversation, your thoughts, right?
Yeah, a quick follow up there. Have you seen uptick, right? You're in the South, warm weather, right? If you're the Pacific Northwest, East Coast, Northeast Coast, you have the changes, or you're not playing baseball all year long, or you're not playing football all year long compared to a warmer climate states. Do you see any differences when you treat a patient that's maybe coming from warmer states where they can play the same sport all year long compared to colder states where sometimes they have no choice but to play multiple sports? Any data on that?
I don't have any specific studies to cite to you on that topic, but I would tell you that I think that most of us would probably agree that there's been a general trend nationally and elsewhere towards year-round participation at a younger age for most of our athletes. And that goes across multiple sports, not just, baseball or throwing sports. So I think that that's a problem. I understand the reasons for it are multifactorial, and there's a lot of people chasing college scholarships and dreams of participating at the next level. And it actually creates, I think, sort of perverse motive that kind of forces everybody to follow suit as you continue to see this decline in sort of truly recreational youth sports, and it becomes this hyper specialized thing where if you're not playing baseball year round, you really just can't compete against the other kids who are. And so it then becomes less enjoyable for kids to participate in sports unless they're doing it year round. So I think that that's a problem that we have not solved. And if anything, I think that's probably getting worse and probably driving some of the trends in overuse injuries in this population.
And that's kind of this slide you guys have up here, right? The kind of the risk of, I think this is really interesting because like you said, I mean, my kids, I'm not a baseball family. We're a swim family, right? My kids yesterday were having a conversation. They're 8 and 10. And my wife's telling me how the other kids are doing like 500 lessons a day, right? They're going to hurt themselves, but that's the way it is. Everybody's trying to one up each other in these scenarios. And it's the same way with baseball, football, you name it. So obviously it's a balanced conversation. So how does you or OrthoCarolinas, et cetera, like how do you get involved in this type of conversation, right? Because it's hard. It's almost like preventative, which is more challenging as surgeons. That's not really we don't really do as good a job at that. At least maybe it's just me, but the preventative stuff is important, but we don't talk about it a lot.
Yeah, I would agree with you. I think that we're more
I seem you lost the audio from Jim, but I'll chime in here. I think getting involved with some of the local sports organizations where you're either your kids are involved or you have patients involved, or just like you said, trying to get on the early side of this. And even the soccer club that my kids grew up playing for, I got in with the coaches early on and talked to them about overuse injuries and what does it look like to have time off throughout the year for some of the kids, just to see if you can build that into the program, like you said, on the preventative side, because it's much harder to work backwards after the kids are injured or they have these overuse injuries, because then they're sitting time out and families are unhappy. They want to be playing and get back as soon as you can. So I think it's very much a preventative thing, which, like you said, is not easy because that's not our forte. Our forte is taking care of people after they're injured and figuring out how to get them back to sport rather than keeping them healthy.
And Jim, I think your audio is working on our side. Do you want to try it again?
Yeah, as long as you can hear me okay.
Yeah, you're good. Yeah.
Yeah, I just can't hear him for some reason. I'm not sure.
He's doing a good job of talking. I can tell you. He's doing a great job.
Yeah.
Why don't you continue with your conversation on the idea of the sports specialization? Like how would you intervene? I mean, you're doing a lot of ACL tears and you're dealing with this. I mean, we can go to that in a second. But like, what do you think how do you think these interventions work, right? Like we know that in ACLs, you can reduce significantly with neuromuscular training, et cetera, which we'll jump to in a second. But from this sports participation, it's a really challenging thing to deal with because it's really hard to tell people like stop doing that, right? Because that's what everybody's doing. So like, I need to do the outreach programs. Are they effective? What do you guys think?
I mean, I think that for the people who walk in the door to the clinic, they're coming in with a specific problem and they're looking for a specific solution to that problem. And so I think our job is two faceted. The first part is to address the reason they're there, and to accurately diagnose and come up with a plan that's going to resolve that issue. And then the bigger question is how do you prevent these issues from continuing to come up? And I think that if you can, if you have the right parent or the right coach or the right athlete, that you can kind of have that conversation about athlete burnout and overuse injuries from over participation and get that concept of cross training and sort of multi sport participation. I think that some people can be receptive to that and other people just aren't going to hear what you're saying. And I think that that's just the reality of trying to have that conversation. But I do think it's worth it to try to broach that topic when you're seeing people for these overuse injuries in particular.
How much responsibility does the coach have when it comes down to taking care of our kids? Dr. Winton mentioned before that not everyone's being diligent about the pitch count. Normally it's like if you throw over, I guess Little League rules are if you throw over 66 pitches, you're supposed to be off for 4 days. There's different rules and regulations. So staying with that, preventative outlook. does some of this need to fall on the parents, the coaches, or is everyone needs to kind of, come together to make sure that we're taking care of our kids and athletes?
Ideally, I think it's an everybody approach, but I think especially in the throwers that I see, it's kids who are playing for multiple teams, so you can't ask the coaches to necessarily be entirely responsible, because if they're playing for 2 and 3 different teams and they're working with a pitching coach, nobody's talking to each other for the most part, so nobody's keeping track of how many pitches you threw Tuesday night for your middle school when you're playing Thursday night for your travel team, and then you got 3 games on the weekend. Or working with your coach in between. So ultimately, I think the parents are the ones who are going to hold a lot of that responsibility, but they're also the ones who are probably feeling the most pressure to keep up with the neighbor down the street who's doing the same thing, and the kid who's beating him out for the spot on the team. And so it just gets caught in this really vicious cycle of trying to keep up with everyone else who they are perceiving to do all of the things that they want their kids to do, but that kid's not getting injured, so why is my kid getting injured? And it's a tough conversation that takes often a couple of visits to kind of get the parents on board with you to understand that a lot of this is not related to a specific moment in time or a specific injury, but it's all of the things that you're doing cumulatively that are where you are now.
Do you guys, maybe Dr. Starman, do you guys find that, obviously, I mean, I brought this up probably multiple times in the last year on these podcasts regarding baseball, but I know there's other sports. Are there other sports you see this in that, and I mean, baseball is just a very particular one for me for the players, but do you see other sports that you see this in, and what sports are those? And how is it different? Is it the same? Like how is that conversation different, Dr. Starman?
So the best example I can think of on that would be gymnastics, which hits close to home for me because I have 2 competitive gymnasts in my house, one who's 10 and one who's 12. And so, I certainly understand the idea of year-round participation in a single sport, because that's essentially the nature of gymnastics. There's really no other option for them to be competitive gymnasts other than to do it year-round. And so, we've dealt with our own set of minor overuse injuries just from the repetitive pounding of landing various flip maneuvers on the floor. And, thankfully, in my house, at least, we've not had to deal with any of the spine issues that can sometimes come up related to spondylosis in gymnasts with all these repetitive hyperextension movements in the spine. But I think that, those are definitely concerns and things that we have to constantly be on the lookout for.
Great. Will, do you want to bring that up? I don't want to jump into the ACLs. I mean, that's a big topic, right? So I don't want to put you on the spot with the Freddie Fu stuff, but are you still a proponent of, do you do double bundles ever, or do you mostly do single bundle ACLs?
So I do 100% single bundle ACLs, always have. And I think that obviously Dr. Fu's legacy is double bundle, and it always will be tied to that. But I think that he would probably argue that his legacy should really be more about anatomic ACL reconstruction, more so than double bundle as a technique. And I think that is probably the greatest thing that he helped me learn with respect to that surgery, is how to place an anatomically correct graft. And so I think that that's really been my focus, is trying to make sure that I'm getting as accurate graft placement as I can. And I go so far in my cases to actually use fluoroscopy on every case to make sure that I know exactly where my tunnel pin is going to be placed before I drill my tunnel. And that's based on some of the techniques that he had made use of when I was with him, observing him. And so I think that that's really, to me, the best lesson that he taught me as it relates to ACL surgery. But I think that double bundle, the literature is out there. I certainly don't think that anyone is obligated to use 2 bundles to recreate the anatomy. But I think at this point, I would hope at least that we can all agree that there are 2 bundles.
Yes.
That was something of a debate for some people, but yeah, he definitely did quite a bit to stimulate the discussion on that topic.
Well, and again, the goal was not to be a controversial one. I love that conversation. I like actually where you went with that. I think that we're going to jump to this in 1 second, But the idea you brought up of the well done ACL anatomic, right? If you do ACLs, you probably do revision ACLs, and a lot of times you do it for non-anatomic ACLs, probably the most common reason. So the idea that you're focusing on that is really great for the athletes, because like obviously we want to reduce ACL risk, which we can talk about, but we also want to make sure when we do it correctly. So that's a really important point you brought up. And the idea of maximizing anatomic, there's some companies coming out with CT guidance for some surgeons to do ACL tunnels. And so it's just a really interesting topic that we could bring up at some other point, Will, to talk about how you get so precise, right? Because it matters. Would you agree? I mean, you really want to do a good job. Like you've got one shot.
Oh, absolutely. Yeah, I think there's no way to recreate 100% of the footprint with a single bundle graft, but if you have it in the right spot, you're going to get just the right amount of PL and AM to give you that anterior translation control in addition to the rotational component. And I think that absolutely 100% impacts people's results and their ability to recover and probably the risk of re-injury as well, for sure.
I don't want to leave out Dr. Winter. He's always been adding good conversations here. Would you help us out with this slide to talk just a little bit about this? I think that I get this a lot. Like my friends who have young female athletes always are like, why do you do more ACLs in females than males in certain age groups? And they, they hear about it, but they don't know enough about it. And I have to try to explain it to them. So it's good that we have this slide.
Sure. Yeah. Happy to chime in. Yeah, I think like you see a lot of female ACL injuries. I see a lot of soccer players with ACL injuries and basketball as well. Seem to be the two big ones around for me anyway. But yeah, female has a little bit wider pelvis, so increased Q angle, so more valgus stress at the knee. A lot of people looking into ligamentous laxity and whether there may be some component of hormonal cycle changes that increases ligamentous laxity during certain times of a female cycle that may put them at increased risk for injury. Certainly, changes in intercondylar notch, somewhat narrowed notch in females seems to be higher risk for ACL injuries, and then changes in muscle strength and activation. Certainly somewhat more hamstring tight seems to be somewhat of a risk for folks.
A question for you guys, both of you, on the notch thing, because this just came up. Someone was asking about this when I saw it doing surgery. Do you guys always? I'm a routine notchplasty guy. I like to see the back, the lateral wall. I know we're getting into the weeds here, but do you guys find that, like, I feel like in females, I try to improve that notch. So if I'm going to do an ACL as an impinge, is that common for you guys, or you guys are fine with not doing that? How does it work for you?
For me, I'm not a notchplasty guy. I've never done them. Yeah, I'm not really a big proponent for that.
Okay.
I do it probably 20% of the time, depending on what I see during the operation. If I think it looks fairly narrowed or can't see back to the back corner, then I'm probably doing a notchplasty.
All right, cool. Let's go to the next slide. I want to know this one. So these landing issues, obviously you can see them. So in some of the places, like in your institution, do they have you guys measure this for the players? Like obviously you can see here that somebody did these measurements and stuff. Explain this to the listeners or viewers. We'll go with Dr. Starman.
Yeah, so for landing in valgus, it's going to increase your load on the ACL. This is not one that in my practice that we routinely monitor or measure. Just with the setup that I have in my office, we're just not really equipped for this particular type of measurements. So it's not something that I normally routinely use, but I'm not sure, Brad, if you do that at all in your practice.
Good done. Dr. Winter, he wants to know if you do the same in your practice, or do you guys have physical therapists that you work with that do this, or trainers?
I have a conversation about this often with patients in the office, but really having the therapists working with folks on this when we start the kind of more sports specific phase of ACL rehab. So kind of the 6 month plus phase for me is when we're working on a lot of this stuff. But yeah, I haven't paid close attention to valgus knee landing or valgus positioning, and Certainly the hyperextension at landing as well. I think these videos are probably from the Charlotte rehab group. I think they have a little more video technology than we have in our therapy office to do some of this.
Do you guys focus though? I mean, do you ever talk to the players? Like, I have this a lot where the ACL's done and they worry about the other knee, right? They come in, they ask about that. I think since Dr. Winter, you're speaking, do you ever have that conversation with them? Like, in theory, right? There's higher chance of re-tear on the other side. So is that the preventative conversation? Then you get to chime in because, right, you're not really if they haven't torn their ACL yet, you're probably not seeing them at the beginning before they have that. So
every once in a while, you get a sibling in the room. You're like, "Hey, do these exercises so you don't have the same injury." But most of the time, you're right. You're talking about the other knee. I have the big group of soccer players, somewhat because I'm plugged in with that community. My kids play competitive soccer, and so I get more of those kids just being around the fields and things. So, a lot of the female soccer players, I'm having conversations about how do we decrease the risk on the other knee. Some of the FIFA 11 warm up and cool down exercises, and then specifically some of these preventative type situations of preventing knee valgus when you're landing primarily is what I'm discussing with them.
Got it. And Dr. Starman, how about you? What kind of conversations do you have with this sort of you get the athlete in, you've done the ACL surgery, or maybe it's a partial ACL and you're going to try non-op. But that conversation, what's that conversation like for you about this sort of the landing methods or ways that, can you make, they say, hey, how can I reduce my chance of ACL tear on the other side? Or how can my sister not get it?
Yeah, I mean, for me, it's when I'm kind of reaching the 1 year point with somebody who's been reconstructed, I'm focusing most of my conversation on the operative knee and the concept of graft maturation, and how that relates to risks moving forward for mostly for the surgical knee, and trying to put that in terms relative to the contralateral side so that they understand that at 1 year, their risk of re-injury is roughly equal to their contralateral knee. And at 2 years, that, as you point out, that the risk of injury is actually less on the reconstructed knee than it is on the non-reconstructed knee, which I think is helpful for some athletes in terms of the mental hurdle of getting back into participation and trusting that knee that's been reconstructed.
That's a great point. Will you explain that to the listeners and Will and everybody else? What do you mean by the maturation of the graft?
Sure. So when we're reconstructing the ACL with whichever type of graft you're selecting, whether it's autograft or allograft tissue, the graft tissue that you put in has to go through a process of integrating with the body and turning into what would be equivalent to a ligament histology wise. And so that takes time, and that's something that is really not a function of how hard someone is working at their rehab process, but it's just a biological process that takes a defined amount of time, and that's directly correlated with the risk of re-injury. And so we know that around 3 or 4 months post-surgical, that the load to failure for the graft tissue that we've placed is actually less than at the time of which the surgery is completed, and by roughly 6 to 9 months, that it's starting to get stronger, but still not as strong as the native ligament. And then by 1 year, it's typically equivalent to the normal load to failure strength of the ACL, but not until 2 years is it actually at its maximum, which actually becomes less likely to re-injure than the contralateral native ligament. So I think that's a concept that I think is important to note for people that have this kind of idea that they're a fast healer, and if we can just work hard enough, we can get them back to sports faster. And you have to kind of debunk that idea and tell them that this is not something that they're in control of as much as they would love to be.
Awesome.
Dr. Winter, there are a lot, I'm assuming there's a lot of difficult questions, right, that you have to have with the patient, with the family, for all of you, right? But directed to you, Dr. Winter, well, how difficult is it to tell an athlete maybe right before an injury or they've had a small injury that they need to back down, right? We started off the show with everyone wants to be at the next level. Now NIL has added an extra element, just like the cherry on top with the whipped cream, where everybody wants to be a pro athlete. There's so much money to make, not even at the pro level, but at the college level. But what are some of those difficult conversations you have when you have to tell an athlete with someone, I need you to back off. And that might be in their senior season and having those conversations.
Yeah, those are tough conversations. Having played, I think helps. Having an understanding what that feels like to be in that moment in time in life and have an injury to kind of have some understanding of where they're coming from is helpful. I think one of the bigger challenges we have is a lot of these people, we don't have a relationship. The first time you see them, they come in with a new injury and you may never have seen them before. You may not know the family. You may not know the athlete. And kind of establishing the trust and the rapport to say, like, this is important that you take this time off and you understand what your injury is. And this is what the rehab timeline looks like. And getting the buy-in from them and understanding, especially if you don't have advanced imaging yet and you don't have like real data to say this is the injury and this is the time we need to spend out. Just like we need to start from scratch. We need to kind of build that trust to say, like, we're going to be out for a certain amount of time. We're going to get you through this. This is the approach we're going to take. This is the timeline I think we're looking at to get you back. Because you're right. Nobody wants to hear you're out, but everybody wants to hear what's the timeline. That's always the next question. When can I return? When can I start practice? When can I look at playing? So trying to get that timeline as quickly as possible for folks, I think starts to establish that trust again and starts to get you to the point where you can have those more realistic conversations of, what does this look like? How long is my rehab process? And when do you see me play?
So this is an interesting, maybe side question we'll go with Dr. Starman first. With your return to play criteria for particular surgeries, do you ever change it for a different athlete, or do you keep it the same for the kind of the procedure, like an ACL or, meniscus repair or something else? Like how does that approach for you work, or how do you feel about that?
Yeah, so I think that's a great question. I think that as we evolve as orthopedists, we're seeing more and more of this sort of notion of personalized medicine that's not just cookie cutter, not just following a protocol written on a piece of paper, and looking at the goal of the athlete, the specific injury, the quality of the repair or fixation that you feel that you have, and sort of the risk tolerance for that patient and kind of what's at stake. And so I always talk with people about, in particular with overuse injuries, when people are trying to get back for the end of their sports season, and kind of what are the stakes of that season for that athlete and what are the stakes of that injury for that athlete. And so there's definitely situations where I'll allow somebody to try to go and participate that may end up not being able to kind of perform at their desired level or even, fully participate. But for them, it's really important to get that last 1 or 2 games in of senior year of high school in football or basketball. And as long as it's not something that's going to put them at an undue risk long term, I think that's a reasonable conversation to have and kind of let that athlete make that decision with their parents or with you as the treating doctor. But I do think that we're going to see more of that moving forward, and as we have more insights into these rehab processes, I think that becomes a more achievable thing to do.
Excellent. Dr. Winter, do you feel like so this may be me again, just talking out loud, and there's no data on this, but this for shoulder, I tend to see that shoulder return to sport in my practice is a lot more variable than the knee return to sport for some reason. Like I'll have labor repair patients that are like, you're ready to rock at like 4.5 months. And maybe I'm crazy for letting them go back, but or 4 months. And they're like, they're begging them football players. And some guys take like 6-7 months. Do you notice a little more? I mean, you do both knee and shoulder. So do you notice any variability in that? Am I crazy for seeing that? Or is that something you've seen in your practice?
I definitely see the same. I have some instability patients too. I mean, at 2.5 months, you're like, I can throw, and I'm like, oh, let's hold on. I'm not sure we're ready for that yet, or I'm ready to play football. I'm like, well, you may feel that way, but the biology isn't there yet, right? The biologic phase of healing isn't quite there. But yeah, I totally see the same. I mean, interesting story to the point of, do you change your rehab? I had an instability case in a soccer player, which is not very common, but I felt like we could get him playing again relatively quickly with pretty low risk. And parents were ecstatic. She's like, oh my gosh, we're playing at 3 months. That's incredible. But yeah, I definitely see a lot more variability, I think, in shoulder than knee. Some of it may be my own bias about ACL graft maturation, to Jim's point earlier, of like not really wanting to stress that graft too early or in the rehab program, and just probably sitting on some of those a little longer because you're waiting for really the biologic healing, more so than is the knee rehabbed or not.
Well, it's also probably, it might also be too the weight bearing status, right? Like you're just constantly stressing that graft versus like, they're playing football, right? One big hit, maybe one that's going to stress it, but they're not always getting constant stress on the shoulder. It's just a little different. Baseball's different, obviously. I want to make sure we have time because we want to make sure we have time, and this always happens with these conversations. To switch topics, because I know that the aging athlete is a really interesting one. This is actually the one that gets a lot more hits because the people talk a little bit less about the aging athlete. And now with like regenerative medicine, people aging, everyone's, the 40s the new 30, 30s the new 20, 60s the new 40, who knows? So we have a slide on that. I want to bring it up and maybe have each one of you talk about it. Will, you want to pull that up for me? Sure. So I don't accidentally delete it. So can you guys talk about this? Let's say Dr. Starman, can you kind of go after this and talk about this, what happens? And, we won't doom and gloom this because we have the next slide on how we can keep people strong.
Sure. So just kind of taking it from the top here. So obviously, as we age, a lot of things change, and that is certainly true of our muscles as well. So physiologically, we see a decrease in muscle mass, which generally accelerates as you age. The overall strength comes along with that, and the ability to recover. So as we age, we lose muscle mass more easily, and we struggle to build it as quickly as when we're younger. Going along with that is a decrease in bone density and our joint cartilage integrity. So we see kind of irreversible changes to the cartilage surfaces, which open them up to more cracking and fissure development and flaking off of the cartilage and general thinning. And then obviously we see osteopenia and that continuum towards osteoporosis. We see decreases in the elasticity of tendons, which makes them less able to adjust to kind of sudden loads and changes in length, which obviously can lead to a higher rate of strains and tears. Slower recovery and tissue repair, which I think anyone over the age of 40 needs no explanation of that, myself included, and a gradual decline in the VO2 max and endurance capabilities. So a lot of these injuries that we see are overuse injuries, tendinopathies, stress fractures, bursitis or inflammation related changes, degenerative changes, which the big one, of course, is osteoarthritis of the knee or other major joints, meniscal labral tears, which is kind of a breakdown in some of the surrounding structures that provide cushioning to these joints, and other tendinopathy changes, including the rotator cuff, Achilles tendon, which relates to decreases in some of the blood flow to the watershed zones of some of these tendons. Hamstring injuries with decreased flexibility and tissue resilience.
Awesome. And then I think,
can I add? Yeah. I just wanted, so can you give us a, Cliff Note version for things for us to look out for, right? Because you mentioned the Achilles, you mentioned the hamstring. Obviously, if we get older, a lot of us don't do a good job of elasticity, stretching, besides the strength training. So if there's something there that you could say, hey, you're gonna go out, you're gonna play ball on the weekends, you're gonna do certain things, make sure you should be doing at least these 3, 4, 5 things. But Starman, I'll start with you. He's Dr. Mitch is not here. Okay.
So yeah, the things that I always emphasize are the ones that I also don't like doing, which is stretching and warming up, because I think our tendency, especially when you're pressed for time, which many of us are at that point in life, is to just go out that front door and start moving. And it really makes a difference to take that extra 5 or 10 minutes just to warm your body up properly, and also to focus on cooling down when you're done with your activity. So I think that's one that we all probably could do better with.
Are we talking a dynamic warm up?
Yeah, I mean, just static stretching and some dynamic warm up stuff, I think, is both important. And some people do some heat on their muscles before they're getting started. And so I emphasize a lot with heat before activity and ice when you're done with activity, as a way to kind of get the blood flowing to the muscle tissue before you're asking it to perform, and then to limit inflammation at the end of whatever activity you're doing.
Yeah, Dr. Winter, we talked about a couple different things here, but what are some of the things that you have to be concerned about? Because unfortunately, we don't have a cure for arthritis, right? And we're getting old and we're still being active. Well,
Not yet. Well, not yet.
how do we play within the constraints of having arthritis and trying to be safe, but at the same time still participating and living our lives? Do you have any recommendations there?
Yeah, I mean the old adage is motion is lotion. So you got to keep moving. Got to keep flexibility. Certainly I think I didn't hear everything Jim was saying, but warming up, cooling down, flexibility is going to be important. And I think managing symptoms kind of over time, understanding what drives your symptoms. Is it playing 3 games instead of 2 that's going to make you more sore and have more trouble getting around the next day, or can you manage with icing after you play, with periodic NSAIDs, and then of course to the explosion of these new biologic treatments. How does that help manage some of your more long-term symptoms, and can you mitigate some of the 6-month return issues of cycling through injections and things with some of these biologic treatments that I would say we don't entirely know what the answer to that is, but certainly some promising outlook there.
Dr. Winter, will you elaborate on the biologic thing? That's a really good one. And especially like how in your practice does you integrate it in both the non-operative as well as the operative side of things? Because I mean, today I got 2 people on non-op and 2 people on the op side asking about biologics.
Sure. Yeah, I think for my practice, I'm using it mostly in knee arthritis from a front-end non-operative side. I think that's where evidence is probably the strongest, other than some tendinopathy stuff, so some tennis elbow.
Are you talking mostly about PRP or other biologics?
Yeah, PRP for me is pretty much all I'm doing at this point. But managing knee arthritis symptoms in folks who are either not at the point where they need a knee replacement or ready for a knee replacement, or want to do activities that the folks who do knee replacements are telling they shouldn't do, and are trying to find other ways to keep playing basketball and whatever else. And I think we've had pretty good success with that. It certainly isn't a perfect science, and not everyone gets as much relief as we'd hope. But it is another option that we'd have, another tool that we have to manage some of the symptoms, to keep people playing, to keep people exercising and doing the things they enjoy. And I think as we have those discussions with patients, really trying to understand what is it that they want to get back to, and how can we help maintain their level of independence and ideas about exercise that are keeping them either healthy or active, or enjoying the activities that they're doing, so they're not coming home hurting and trying to manage their symptoms for the next 6 days so they can play basketball on Saturday again.
100%. Dr. Starman, will you chime in? Oh, sorry, Will, keep going.
No, I'm asking the same question. Go ahead.
Yeah, Dr. Starman, chime in on yours. What biologic options do you think about, or anything, some of the sports stuff as well?
I'm pretty similar to Brad in the sense that, I'm mostly just PRP and in fairly limited amounts. For my population, the biggest barrier is cost, and lack of insurance coverage, which I think, unfortunately, that kind of limits for a lot of my patients who can get that treatment. But I agree with Brad. I see that as an option for people with mild arthritis and certain tendinopathies, but not a whole lot beyond that I'm recommending that for most of my patients. And I think, to Brad's point about trying to understand the goals of your patients with respect to maintaining that aging athlete in whatever sport they're participating in. Some of that is coaching them on how to participate differently in a sport that they've done for a long time. And, the example that comes to mind for me is with skiing. As a downhill skier, I've done plenty of moguls in my day. And as I age and get a little bit older and you realize how hard that is on your knees, I think, looking for other ways you can still enjoy and participate by maybe doing some of the different runs that maybe don't have quite the same level of intensity and still getting the enjoyment out of that. So I think having those conversations and trying to help understand what a specific person's goals are for participating, and trying to guide that conversation, guide that thought process for them to help them discover what they can do and do with enjoyment is important to have that.
I think probably we'll bounce on both of you guys, but maybe I'll start Dr. Winter. Do you guys have anything you like to do? I mean, at the beginning of the show, we talked about one of the companies we work with, but we talk a lot about, but we've had people on here for nutrition, sleep, other active recovery options. Is that something you guys ever think about in your practice? Or do you ever, I mean, the nutrition now is hot, like you could see it everywhere online and people talking about it. Do you have any thoughts on that? Or what are your thoughts on that sort of future of that stuff?
We don't have a really robust program to walk patients through post-surgical nutrition and supplements and things. I mean, that's a question we get all the time, is what supplements can I take that are going to help me heal faster? What do you think about insert your favorite supplement that is new on social media?
I get BP 157 literally every week.
Yeah, that's the hot one right now, I think, for sure. But it morphs over time. I mean, 2 years ago it was CBD. Now it's BP 157. Yeah, who knows what it'll be 6 months or a year from now. But trying to keep up with that, trying to understand what does it look like to coach people through eating the right foods. So, eating clean, healthy foods, fresh greens, lean proteins during healing and post-surgical phases, and then managing other symptoms like we use magnesium a lot for folks who can't sleep, from shoulder pain up to shoulder surgery. There's a few studies that show it can be helpful. And just how do we coach them through that without having a dietitian on staff or really a lot of formal training and dietary kind of questions. So learning as we go, I guess is my take.
And I would echo that, and also say that I think it's important to make sure patients understand what is being promoted on some of these social media nutritional supplements. I know one I just saw in the news recently had to do with a lot of these protein supplements that were found to have high levels of lead in them, and obviously that's not something anybody wants to put in their body if they know about it. But I think people don't always understand that stuff that's not regulated by the FDA, you really just don't exactly know what you're getting with any of these products. And so it really truly is buyer beware, which I think some people are comfortable with that and other people maybe aren't. But I think it's important that we educate our patients on those risks.
It's a conversation that's challenging sometimes. I mean, when we've had nutritionists on, there are certain things we can't talk about on the show from a perspective of doctor, because it's not really considered something you should be having a conversation with a medical professional. So it's important. You're right. Like on social media, you can say whatever you want, but it doesn't mean it's accurate.
Yeah.
I was just going to chime in. We're talking about all the different things. What about specifically? What is there wearable technology or anything like that you're recommending, perhaps with a patient, whether it's post surgery or anything like that? Is it something that you guys do in your office with that, kind of biotech and things like that?
I wouldn't say I have a lot of experience with patients, but one of my sons wears one for soccer that we monitor his load based on how much he's training, how many practices he's got, how many games he's got on the weekend. And we're watching how many miles he's running. We're looking. He likes to look at his top speed, which I tell him it's not that fast. But
classic kid.
Yeah.
That's okay.
Exactly. But I mean, I think it does give you a lot of information. I think especially if folks have muscle injuries, it probably is a valuable tool to understand how much load you're putting on those folks. So, people with hamstring injuries, quad injuries, that you're trying to ramp them back up slowly without overwhelming the system.
I want to chime in real fast, Starman. I had a patient today. You'd like this, Dr. He said he had his Aura ring. He says, I know I need my rotator cuff fixed because I woke up 12 times last night. That was what he told me was the indication for the surgery. He hadn't gotten the MRI back. He's like, I have woke up 12 times because my ring told me. Was he right? I need to have. Yes, he was right. But nonetheless, it doesn't matter. Sorry, Dr. Starman, keep going. You just answer that question for us, please.
Yeah, I mean, I don't really have a whole lot more to add to what Brad said on that one. I'm not really using that routinely in my patients, but I do think it's a very interesting technology, and I think it's kind of fascinating as a spectator at the professional level to see some of the monitoring from a performance standpoint and all the amount of data that's able to be collected on these athletes at the really elite levels and how they're able to apply that back to improve performance and probably also to drive some of the training.
So as we always do, we are very close to running out of time. Maybe, Will, I know you always have fun questions, but I wanted to ask one more for each of you. Maybe since Dr. Starman started, where do you think kind of both sports, so where do you think the future of stuff that you like is going?
Yeah, so as far as sports medicine, I think to me the most exciting thing that's coming down the road is kind of related to personalized medicine and what artificial intelligence may influence in that realm. So I know AI is kind of like a hot topic in all realms of life at the moment, but I think as it relates to sports medicine, the potential upsides of being able to integrate the vast amounts of research data that have now been generated and to kind of integrate that in a way that we can benefit individual patients. Really, AI is, I think, one of the more exciting options that we can use to achieve that. And I think that we need to, kind of do our best to find ways to integrate that technology into how we practice and to not see it as a threat to what we do and to see it more as an opportunity. But I think that that's really the only reliable way that we could potentially integrate all of the data that's been generated with research over the last 20, 30 plus years in this realm in a way that can become useful for individual patients and for us as clinicians to make those decisions about treatment and rehab and specific surgical techniques for specific patients.
Awesome. Dr. Winter, how about you?
I think, Grant, you brought up, navigated surgery and patient-specific imaging, integrating the surgery. I think there's a huge opportunity there, especially with wearable devices like glasses and things that you may be able to wear during surgery that could reference imaging. And can you overlay that to like real life anatomy, and actually see the imaging overlying what you're looking at in surgery that could be revolutionary in terms of really getting patient specific to like the millimeter detail, which in theory should give us really, really good anatomic outcomes from surgeries. I think the other is the ability to put a camera on a needle at this point and potentially start to do even less invasive operations, maybe even requiring less significant anesthetics. Could that push us to even more rapid outcomes? And then combine that with the biologics. Can we get even faster healing? Can we get more rapid ingrowth of implants and grafts and faster biologic healing so that we can rehab folks even faster and get them back quicker?
I love it.
That's great.
Excellent.
All right, let's wrap it up. That's a great way to end the show. I'm really excited, especially as a patient, to hear that you're going to cut me less and find ways to kind of advance technology and embrace an AI. I'm always wondering how a Pitt guy that went to Virginia is now in Tar Heel country. I don't know how that all works out and how the fandom does with all the colleges, but I'm pretty sure that it all gets worked out. Big thanks to Dr. Starman and Dr. Winter from OrthoCarolina for joining us. Thank you so much. Dr. Garcia, any last words as we say goodbye?
No, thank you guys. It was great. This is our first 2 guests out of time. You guys did awesome. I really appreciate it. So thank you.
Thank you.
Yeah, thanks for having us.
All right, take care. Bye-bye.
Yeah.